Thank you for choosing Access On Demand. Access believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Thank you for joining us for a conversation on home health value-based purchasing, where you will gain understanding, hear about lessons learned, and success strategies from two of our national leaders today. Hi, I'm Deborah Hoyt, Senior Vice President of Public Policy at Access. Access is pleased to present this on-demand webinar as part of our educational series to ensure that the future of healthcare is in the home. As healthcare delivery continues to evolve, all of healthcare in the United States is moving to a value-based purchasing model, and that includes home-based care. Simply, value-based programs reward providers with incentive payments for the quality of care versus the quantity of care provided. Home health value-based purchasing, or you'll hear us refer to it as VBP, began back in 2016 with 9 states piloting a demonstration project, which proved over time to deliver positive results for CMS and for home health patients. The project resulted in an average of 4.6% improvement in home health agency quality scores and an average annual Medicare savings of $141 million. This success has led CMS to issuing a national expansion of the home health value-based purchasing model beginning in January 1st, 2022. I'm delighted to have 2 state association leaders join me for today's conversation to prepare your agency for value-based purchasing success. First, welcome to Thomas Mills. Thomas is the board president of the Tennessee Association for Home Care and the administrator of Quality Home Health, a home care agency based in Tennessee, one of the demonstration project states. And Joe Russell. Joe is executive director of the Ohio Council for Home Care and Hospice and a state lobbyist who is very engaged in state and national health policy. Welcome, Joe. Welcome, Tom.
Thanks, Deb.
Thanks, Deb. Glad to be here.
Well, it's good to see you both virtually. So I guess let's get started. Under the final rule, CMS will assess achievement or improvement of home health agency performance based on designated quality measures. The first steps to achieve improvement include awareness and understanding. Joe, you've been working on this for a couple of years. We know, Joe, we know that Ohio has not been working on this for the past couple of years, but based on what you've heard, what do organizations need to understand before the national value-based purchasing expansion in just a couple of weeks to succeed under this new payment model?
Yeah, thanks, Deb. It's a really important question. And I think to really understand improvement, I think it's important to first take stock of why value-based care is a thing. Payers have a problem with paying for something in which they're not sure what they're getting. And this is sort of tantamount to going to your favorite restaurant and expecting to buy your favorite burger only to receive something completely different or something you didn't expect. Payers want to know what they're getting and what they're paying for. And so they're looking at reimbursement models differently than ever before. The fundamental issue with the current reimbursement models that exist, especially through the government payers like Medicaid and Medicare, is that they pay providers the same no matter how good they are, which means that providers have really zero incentive to improve and innovate. And the goal of value-based reimbursement models is that we start reimbursing for how good providers are and how quality of care and basically patient outcomes, not just did you do this task. So a lot of people, when I say that, they say, okay, Joe, well, what is good? What is quality? Those are good questions. And the answer to that question lies in really what's good for the patient. Whether providers know it or not, PDGM kind of took a step in that direction. And so while providers may not understand value-based purchasing, they ought to be able to see where this whole thing is going. Simply put, value-based care gets us to a place where there's not one size fits all, but rather we're giving the patient what they need to reach an outcome, no more and no less. And once we understand why value-based care is a thing, then we can really understand improvement and achievement. Value-based purchasing is not something unique to home healthcare. In fact, it's being looked at across the healthcare spectrum and being tested in many other sectors. And so while people would like CMS, frankly, just to leave us alone, I hope that folks can understand that they're really priming us for the big time. They're seeing where healthcare is going and toward in-home care, and that they want to make sure that they're paying for what they're getting. Achievement and improvement in value-based purchasing isn't about who's the best. It's about empowering providers to put systems in place to improve over time. And so moving from a 1-star to a 3-star as a very, very basic example might be a bigger deal to a payer than an agency who's moving from a 4-star to a 5-star. And we're certainly beginning to educate our members about these basic concepts now and slowly drilling down on the details. In general, we believe it's important to show providers how to do this rather than just to tell them. So that's kind of the basic thoughts that I have. Thank you, Deb.
That was really helpful, Joe, because it put in perspective really where we're going as a nation. And I really like that bigger picture. So thank you for sharing. So I want to turn to Tom, because Tom's agency was one of the 9 early implementation states, and he's been experiencing this for the past couple of years. So Tom, can you share your personal perspective of your journey as a leader in an agency in Tennessee? And how did you operationalize CMS's expectations and engage your agency staff during the transition so that they could buy in and you could roll it out in a positive way within your agency?
Well, thanks, Deb. Again, that's an excellent question. One of the things that we did at the get-go was we established a quality assurance performance improvement, what we call our QAPI team. And that's made up of all of our clinical managers in all of our offices, as well as our management and administrative team, key people from social services, therapy, human resources, our wound care program. And that all came together to say, how are we going to put together a plan to accomplish the goals to make improvements? So off of that group, we established a OBQI, outcome-based quality improvement team. That team worked each quarter to evaluate results that we were getting from CMS and look to say, where are we deficient? Are we deficient in oral medication management? Are we deficient in dyspnea? Are we deficient in moving around or improving activities without pain? Are we deficient in rehospitalization rates? So we took those items and we said, we've got to have a plan to each office in itself is competing against their standard, not each other. And we had to put incentives in place. So we did that. And I know I'll talk a little bit more about incentives as we go along. But one of the things was key for us is we have a lot of rural communities in our state, and we serve some of those rural communities. And hospitalizations is a big deal because we don't have ambulatory walk-in care clinics on the weekend. You know, the doctors, they're not on call because they're not with a hospital. So it was like, if we got a hold of the physician, it might be send them to the hospital. It's like, no, we don't want to send them to the hospital. So we tried every way possible to provide an intervention with a visit in the home with our on-call staff in order to prevent that rehospitalization. And we are still, that's one of our biggest key focuses is rehospitalization.
Thanks, Tom. I really like the way you engaged your team fully around it and making sure that the patient was really the center of the quality outcome there. That was really a great way to approach it. And it seems as though you've been successful with it. I think we'll hear more about that. You know, Joe, I wanted to go back to you about how Medicare is going to take a look at this over the next couple of years. So we're hearing that Medicare is going to penalize or reward agencies with a maximum of a plus or minus 5% reimbursement based on their scores in comparison to other agencies beginning in 2025. So, Joe, I know you run an association with already tight profit margins for your member agencies, you know, what they're experiencing with Medicare and all the other things that are happening with payment adjustments under PDGM. Can you talk a little bit about the potential impact of margin adjustments under the value-based purchasing model on home health agencies in your state or what you're hearing nationally?
Yes, Deb, it's another really important question. And I think looking at this change through the lens of, how agencies make ends meet is really critical. It's certainly the way that these agencies are looking at this is, at the end of the day, how is this impacting my bottom line? I think what's really important for agencies to understand is that there are, while there's certainly some vulnerabilities, there are a lot of opportunities as well. I like to kind of use, analogies when I think of this stuff, and one of the analogies I've been repeating over and over again with our members is serving tables. And I know I used a kind of a burger example before, but I'll use a restaurant. In college, I waited a lot of tables, so it's applicable. If you ever serve tables, you know that there's sections, and you've got bigger table sections and smaller table sections. Well, the way that a lot of folks might think that if you have a section of small tables, you're not going to be able to make as much money as if you're serving tables in the big table sections. Well, that's actually not true. There are strategies that you can put in place to actually make more money by flipping these tables, by getting them in and getting them out faster. I know we're not talking about restaurants here, but the point that I'm trying to make here is that the agencies who look at this through the lens of opportunity and make changes to the way they're conducting their business, the way they're providing care, can really find ways to leverage those opportunities so that the margins that they have don't really become an issue. I mean, look, if you're in this business, you're already dealing with the government. You're already dealing with regulations. There are certainly going to be agencies who cannot manage and survive these changes. That there's no doubt about that. But the question really becomes is if CMS is priming our industry for the big time, and we've got agencies who are completely unwilling to understand that patients need to come first and that we need to provide care that's good for patients rather than what's good for my agency, then are those really the type of agencies that we want to be supporting anyway? And maybe that's too broad of a question, but I think if we look at it through that lens, then we find opportunities, and our heartburn with these margins become less relevant.
Thanks, Joe. I really like how you frame that in terms of opportunity. And I think that for an agency to be successful and look at it as an opportunity, they have to do what Tom did. They really have to look at measurement and data collection. So we know that calendar year 2022 begins this pre-implementation year for data collection by CMS. So that makes calendar year 2025 the first payment year based on the agency's performance in 2023. So it's a little complex, but I think that the agencies are understanding this, and we're appreciative that CMS actually gave us this pre-implementation year. So with that framework, how can administrators and managers track their agency's progress now and plan for positive or negative Medicare reimbursement adjustments in the years ahead?
Yeah, so we're dealing with a lot of things right now. Obviously, in the state of Ohio, we're still supporting our providers with a myriad of other different regulatory changes that have come down the pike. But we are certainly talking heavily about this change, and we're taking stock of where providers are. It's not abundantly clear from the broader scope of where our agencies are in terms of the level of preparedness. I think there's different, folks feel differently about this. But we're very confident that all of our providers have the capacity to work through these details. I mean, look, PDGM and RCD, Ohio was an RCD state, pre-claim review. They have been significant changes for our providers. And when they first started, there was a lot of fear. In fact, I remember working with the Access team when you guys came to Ohio for our PDGM summit. And there was a lot of fear from people about how we were going to implement these changes and what these changes mean for our agencies. And we've worked through them. And at the end of the day, people are starting to see, well, these changes were difficult to kind of work through at first. They are making a discernible difference and helping their agencies be more effective and efficient in delivering patient care. I think what we're starting to see is an attitude shift, and we're seeing that a similar attitude toward the VBP change as well. We definitely have our fair share of education events to get them prepared, but many of our members are already becoming more sophisticated through some of the work that they've already been doing. And just to provide one example, the Ohio Council for Home Care and Hospice launched our own managed care network called the Ohio Community at Home Network that was intended to help our home care and hospice agencies better establish relationships and contract with managed care plans, commercial, Medicaid, and Medicare Advantage. And what we've seen through these conversations with the payers, what they're looking for, what their levels of sophistication are, and learning their lingo and kind of feeling each other out. And while that project that we have isn't necessarily a direct comparison, it gets us thinking about episodic payment models and value-based care in a very healthy way. And so our members are becoming much more sophisticated in the terminology, and we're very confident that we're going to be able to make the next step. Look, this next year, 2022, I'm glad it's an implementation year, and it's not just we're going to do this right away. We need time to learn, but we have no worries that we're going to get our people to where they need to be.
Thanks, Joe. I mean, that was really helpful, and it's really encouraging actually to hear how you and your association are really addressing this head on. I think that some of the feedback we've been hearing here at Access is that agencies are really interested in continuing to learn, improve, and hone their processes. And I think Tom can tell us a little bit more about that. So I think I want to go to Tom on this next question. Tom, it's important for providers to show improvement towards optimal patient outcomes, right? That's the whole goal of value-based purchasing. So measures used in the value-based purchasing model align with the home health quality reporting program, and also look at OASIS documentation and CAHPS patient engagement surveys. So Tom, I know your agency really implemented a lot of internal processes to link all of this together, but how did your agency look at which patient care areas to improve, and how did you go about it? I guess we're interested in hearing what your results were and what your lessons learned, so that our friends on this call can learn from you so that they can prepare in advance and avoid some of those missteps.
Thanks, Deb. Well, our subcommittee, our outcome-based quality improvement committee, they took this project on to say, what are we going to do to get a cultural change so that we have a lifestyle change, so we live it every single day? So again, they put together where we focus on 3 to 5 key achievement or performance components and measurements each quarter, so that we would, again, like I said earlier, not compare ourselves to, we would compare ourselves to ourselves so that we're improving. And if we improve 3% with the program that we put in place, then everyone got some PTO time. They got paid time off for each quarter up to a half a day. So for a year, they could actually end up earning 2 whole days off. But to do that, they had to improve in so many areas that we identified 3%. So if they were at 78% on one measurement, they need to go up to 81. If they were at 92, they needed to go to 95. And we incorporated many things. We incorporated OASIS, we incorporated the HCAHPS, we incorporated outcomes. It was so important that we look at the things that are key to the patient and patient care and the improvement in that. And it proved to work well for us. We had an amazing uptick the last several years, where we've been in the 4.5 to 5 star, and we've been very pleased with that. But once you get there, you got to stay there, and it's very difficult to do when you're compared to your peer group, and in our case, our state. It's going to be a little different when we get to value-based purchasing nationwide, where you're either going to be, based on a size model with, peers all over the country. So some of the other things we put into place was remote patient monitoring. One of the things that I mentioned before, we don't want patients to get in trouble in the home and have to go to the ER. So for high risk COPD and CHF patients, we put in remote patient monitoring that we did 7 days a week up until this last year, and we're down to 5 days a week just with COVID and staffing. So Monday through Friday, they're monitored, they're triaged. If they're up on level one, they get a call immediately, and we're out the door, and we're there to see them and look at the type of care and if they need to be transported. So some of those things have really helped us to improve our outcomes, reduce the hospitalization, and then we also have in place audit teams. We actually, on every admission, we have an RN that is in a home office, and they sit there and they review every admission for what's going on. What are we missing? Do we have everything we need to make this patient experience wonderful, and can they improve? And then throughout the episode period and episode now, they're monitoring that as well. And so, at the end of the episode, we're going to know, is there improvement or not? Or is there extended need for another episode to talk with the physician to see we can get them there? They just need more time. So, outcomes are key. Just like Joe said earlier, this is the way it's going to be for the future of healthcare.
Thanks, Tom. That is so encouraging to hear. And congratulations. Your agency really seems as though they've got this alignment fully set so that you're going to continue to be really successful. And congratulations on the 5 stars. I think that our listeners here today have a lot to think about in terms of what you just said and how they can implement it within their own agency. So thank you for sharing that.
Can I add one more thing there? One of the things that our OBQI director has done, each time we have our quarterly meeting to review our results and evaluate, did we improve, did we not improve, see how the contests are going, to look at other components of the next quarter's contest. They have put together some fun stuff. We have such a creative OBQI director that she has a Wheel of Fortune game all geared around home health and OASIS and HCAHPS and outcomes. She has a Who Wants to Be a Millionaire game, all built around that. So it's fun, and you're learning as you go. And a Jeopardy game. This past quarter, we played Who Wants to Be a Millionaire. And, some of those questions are hard. They really are, even for those that do it every single day. But it has engaged the staff and makes it fun. And then those clinical managers in that big group management meeting can go back to their offices and share those games and tools with the staff to engage them.
I love hearing that, particularly now when we're hearing that there's, workforce and staffing shortages, and people are really stressed about, the amount of work that they have to do every day to make sure that their patients are taken care of appropriately. You've just made it so engaging and fun for your staff to do the right thing. And in turn, rewarding them is going to make sure that they are going to continue to do the right thing for the patient. So I love hearing that. That's terrific. Joe, I'm just going to go to you just to see if you have anything to add there. That was just such a heartwarming comment about how the staff is being engaged and how creative that is that Tom is doing that for his folks.
I think that's absolutely wonderful. We have to, in general, engage our staff more in this process. At the end of the day, we rely on them to make these systems work, right? So the more we can kind of support what they're doing and give them incentives, and quite frankly, train them so that they can understand how they play an important role in the overall system. I think that's absolutely fantastic. And Tom, if you don't mind, I might have to steal some of that for our Ohio folks.
I think that a lot of people around the country are going to steal your Wheel of Fortune idea, Tom. I think that's so creative. And Joe, I remember when we were back in Ohio a year and a half ago before PDGM was going to roll out, and we were doing those education programs and thinking about how do you motivate your team and your staff to kind of come on board to the next payment model and really get engaged with it. And I think the strategies that Tom's used to really let them be part of the process and help them understand that every single thing that they do with that patient connects to the reimbursement for the agency. And if they're doing the right thing, the agency is going to be more successful and financially viable moving into the future. So sometimes I think administrators felt that they need to handle the finances and the reimbursement and the billing and all of that. and the clinicians are out in the field doing their thing. And there was a disconnect there. So I think this whole value-based purchasing is pulling it together, giving ownership to the staff in a way that Tom is making it really engaging and fun. And Joe, I think the whole industry is going to try to look at a way that we can do that too. So thank you for sharing that, Tom. I want to go back to Tom about tracking and improving quality measures. You talked a lot about what you're doing internally, and technology has always played a great role in making sure that we're moving forward in the right direction in healthcare. So what kind of things should home care providers be looking for from their technology partners? They're critical as we move into this new payment model, and I just wanted to get your thoughts on it.
Well, the electronic medical record and your technology partner are absolutely key to success in value-based purchasing. I mean, if you're not partnered together and you're not on the same page, you will not be successful. One of the things is when you go out there and you have a diagnosis and you open that chart up and you see the patient and you treat them, you need to know really where are they and how can I really work to improve them? Is there a pathway that's going to help me to say, what am I going to have to do to improve the care of this patient so when they're discharged from our care, they've got a positive outcome? And having a technology partner that works with you, one that has models that you can work with, one of the key things is the what ifs. What if they improve in oral medication management? And what if they improve in, ambulation so many feet? But what if they decline in other areas? What does that outcome look like? And I think the technology partner is key in working together, both when you have the device in the field, as well as managing it from the back office with your dashboards and your other evaluation tools.
Yeah, I don't know that there's necessarily challenges per se, but I can tell you that the conversations that have been taking place, to echo what Tom just said, is that the partnership between agencies and their technical partner is never going to be more important than it is under a value-based purchasing arrangement. The reason for that is part of the way the payers are really going to be looking at reimbursement has to do in part with the outcomes of the patient and understanding the full scope of what the patient's history has been, what environment they're coming from, how much they've been rehospitalized, and how well the healthcare at home agency has prevented a rehospitalization. Just to give a very basic example, plays an important role for the payer to be able to identify how good a payer is or is not. If you don't have the data, then you're going to struggle. And quite frankly, I think what we're going to start to see is a move more towards faster quality metrics. Right now, we know that a lot of the quality metrics that are reported publicly are in the rears, and that doesn't allow us to maneuver as quickly as we really need to. And so we're seeing actually a move towards more real-time quality indicators that allow agencies to make changes or evaluate their operation in a way that's never happened before. So the technical partner is going to be, it's never going to be more important than this next phase.
I agree with you, Joe. One of the things that actually we've been doing at Access is we're a CAHPS provider, and they're actually making the CAHPS data available to agencies in real time. Because how can you continue to improve a patient if you don't have data for them and maybe it's 6 months old? So I agree with you that data in real time is really going to be critically important to making sure that we move in a positive direction under this value-based purchasing model. So I think I just have one last question. I'll go to Joe first, and then if Tom wanted to add anything in here. I loved your opening comments, Joe, about kind of the big picture of value-based purchasing. And I'm just wondering if you want to share your thoughts about where do you think this is going to bring healthcare delivery in the home to a point in the next 5 to 10 years? Is this going to be a positive move? Is this going to help patient outcomes? Is this going to stress agencies or maybe close agencies or make us better? And so I just want to get your thoughts on that.
Yeah, thank you, Deb. I I'd not be surprised if in 10 years, value-based purchasing is one of or the predominant reimbursement model. And of course, there's a lot of different models that we're talking about under that label. And it's still a new concept. You know, we talk about bundles, we talk about shared savings, we talk about shared risk and global capitation. All of these have different risk stratification. And there's a lot of different names and concepts that come along with this. They all have their own opportunities and vulnerabilities. I think we're going to start to see those concepts being solidified over the next 10 years. And, you know, look, fee for service is just a dying model. I think not only are we going to see this solidify within at the CMS level, I think we're going to start to see states in their Medicaid programs moving more towards these types of models as well. So if for anybody who hates this and who is afraid of this stuff, buckle up, because the ride's just beginning. This is very new conceptually, but there are still challenges to work through, such as aligning values. While outcomes are crucial in a value-based reimbursement model, rating outcomes can be personal and very hard to define at times. Organizations have to understand what outcomes are going to be important. We're also going to, I think, see an alignment between the government payers and the commercial payers. So, you know, Medicare Advantage and Medicaid managed care plans, CMS and Medicaid state programs are going to start to align in their conceptual thinking. We're already starting to see that. And so when that alignment starts to take place, measuring data in a smart way becomes very important. We just talked about technical partners, and we need those so systems can analyze data, but that only can go so far if the data itself is of poor quality. So we need to be able to track the data. We need to be able to understand the patient population as well. And then we need to be able to prepare for challenges. Switching to a value-based purchasing model from a volume-based one is a major change, no doubt. But I think that this is the overall good change for our industries, because it allows healthcare at home providers to really solidify themselves as the hub. What we've started to learn in the state of Ohio is that the payers and other systems, referral systems such as hospitals and skilled nursing facilities, do not understand technically how community-based care works. And since we're in the home serving the patient, we have the ability to do certain things that, quite frankly, 5 and 10 years ago were just sort of pie in the sky type of ideas including care coordination and some of those other things that we haven't even touched on in today's conversation. I think we're going to start to have these things shake out, but I do believe that, and I think I've mentioned it before, but for agencies who are unwilling to change, I think they're going to have a difficult time surviving in this new world. But people shouldn't be afraid, because we've got through a lot of changes in the last couple of years with other regulatory issues, and we can do it. We can do it again. I think for a vast majority of our agencies, they will do it, and our industry will be better for it. I think, and a lot of people think, Deb, I know you know, that the future of healthcare is in the home. And if we want that to be a reality, we have to figure out a way to make this all work. But I will say one last thing, and that is the model that we're seeing from CMS this next year and then the year after for value-based purchasing will undoubtedly look different in 10 years from now. But we'll have 10 years of experience under our belt, and we'll have fine-tuned the mechanism, and hopefully the tide will raise all boats, as they say.
Thank you, Joe. That's great wisdom, and it provides great context for the agencies that are listening today. I just wanted to give Tom an opportunity if he wanted to make any closing remarks as we get ready to wind up.
Well, thanks, Deb. As you know, outcomes are key, and the outcomes are our future, and it is going to be the way we're going to be paid, probably across, like Joe said, across all healthcare spectrums. And I think as we look now, our referral sources, they can get on HCAHPS and they can look to see how we're doing compared to our neighbors. And they're using that data because they want the outcome and they want the patients the best quality care they can get. So I think it is the future, and embrace it because it really isn't as bad and as scary as everybody thinks. Because once you get in there and you get your culture going, it's awesome. You make the change. It takes a while to do it. We didn't do it overnight. We did it over several years, but it's well worth it because we feel like we give premium care to any and every client that we serve.
Thank you, Tom. Well, our time is up, and Joe and Tom, you've been outstanding guests. I've really enjoyed our conversation today. On behalf of Access and the entire industry, thank you for sharing your expertise. And to our virtual attendees here today, thank you for joining us. Have a great day.
Thank you for joining our on-demand training today. Access is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at access.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Access, empowering care anytime, anywhere.